everyone, and welcome to today's International Nursing Webinars series. I am Dr. Richard Alan Sullivan of the College of Nursing, Central Mindanao University, and I'll be your facilitator for this webinar. We have started this International Nursing Webinar series on the later part of 2019. This webinar is an opportunity for Southeast Asian nurses to build relationships and to disseminate their nursing and health-related knowledge. This webinar is organized by Nursing for Humanity in partnership with Betanu Nursing Society and the Journal of Health and Caring Sciences. Also with Filipino Nursing Diaspora Network and the Educational Solutions for Professional Advancement, or ESPA. The main objectives of this international webinar is to demonstrate and advance the nursing contribution of Southeast Asian nurses, to support nursing contribution to the region's healthcare, and to encourage problem-solving approaches to health priority needs. And lastly, to provide opportunity for the in-depth exchange of experience and expertise within and beyond the international nursing community. Joining me for today's webinar, my co-facilitator is Dr. Rudolph Seymour Kirby Martinez. He is currently the editor-in-chief of the Journal of Health and Caring Sciences, and at the same time, the Research and Linkages Coordinator of San Beda University College of Nursing. So before we start our presentation formally, I have a few housekeeping items to cover about this presentation and webinar platform. First, today's webinar will be available after the live session, and it will be accessible through YouTube via Betanu Nursing Society channel. I have muted you for to avoid background noise, and nevertheless, you can unmute yourself during the Q&A. You can use your chat button and at the lower section to ask questions, and I will read it for you. We would also like to encourage you to share today's webinar with your social networks. Please be reminded that in your registration, please put your full names and your email address so that the certificates will be sent through those channels. Next, on Dr. Martinez to introduce us our valued speaker for the day. Dr. Martinez.
Thank you, sir. So good morning again. I have the privilege to introduce our speaker for today. Our webinar speaker is Professor Gian Carlo Torres from the University of Santo Tomas College of Nursing. His presentation for today will center on the mediating role of patient readiness for surgery in promoting positive surgical outcomes, which was already published in the Journal of Journal of Advanced Nursing. Likewise, he has also developed a tool that measures preoperative patient readiness, which has already been published in the Journal of Perianesthesia Nursing. Dr. Gian Torres is a registered nurse and an assistant professor at the University of Santo Tomas College of Nursing in the Philippines. He has been in perioperative practice since 2002 and has been a nurse educator and clinical faculty since 2005. He obtained his Bachelor of Science in Nursing in 2002 and Masters of Arts in Nursing in 2008 from the University of Santo Tomas, and finished his Doctors of Philosophy in Nursing from the University of the Philippines way back 2018. So without further ado, let us welcome Dr. Gian Martinez. Dr. Gian Torres. Dr. Torres, please.
Thanks for inviting me to share and to have this opportunity to present the product of my dissertation, which was done around 2018. But to be honest with you, my work and my interest on this concept of readiness started as a staff nurse, as a perioperative practitioner way back in 2002, that I have always seen the importance of making the patients prepared for surgery. That's why in my master's paper, I worked on the concept of having a standardized video presentation to teach patients as part of promoting their surgical compliance. And then when I started pursuing my master's in 2011, my doctor philosophy program in 2011. This is like something that I really want to ensure and I want to push as a concept in nursing. It's something that I think that we really need to focus and address in terms of our care. So my studies about the mediating role of preoperative patient readiness on surgical outcomes. So I used the structural equation model analysis for this one. So just some declaration. So there's no conflict of interest. So I am not affiliated with any pharmaceutical or whatever company. And this presentation is something that I am giving for free as well, as part of my commitment to advancing the science of nursing. So to start with, we say that when we talk about the perioperative environment, it is something that is really fast-paced. It is something that is really complex and usually requires some complicated, sophisticated interventions that sometimes leads to an increased demand for the healthcare providers, that we need to be able to ensure something that will be able to somehow address their specific or patient-focused needs. Actually, in 2018, in 2008, the WHO developed the what you call a safe surgery guidelines, wherein part of that it promulgated the development of what you call your surgical safety checklist. So most of the perioperative practitioners are familiar about the surgical safety checklist. So this was established in 2008, and part of that, it highlights on promoting patient safety. It highlights on promoting the surgical environment. However, in that checklist, we cannot recognize, or we did not recognize any distinction or any identification in the sense of looking into the the mental, the emotional preparation aspect of the patient in preparation for surgery. So normally, when you talk about patient preparation, we see it as a focus on doing physical assessment. We do it as checking for the laboratory examination, preparing medications, ensuring that the patient is stable for the surgery. And this is the usual focus when you talk about the term patient preparation. However, if you will look into the model, this is one recommended and developed by Rothrock and highlighted by the American Perianesthesia Nurses. Association of Perianesthesia Nurses, it highlights on not just the safety, not just on the health system, but it also highlights on the physiological response and also on the behavioral response of the individual and also the family. Thus, there's a need for us to look beyond the concept of preparation, beyond the standard physical or physiological preparation or preparing the equipments, but rather we need to also look into the emphasis of highlighting the patient as part of the focus of our care. So thus, when you talk about readiness, it is said that readiness may require more focus on overcoming knowledge deficit. Further addressing specific concerns and outcomes should be prioritized. This is when I was doing my dissertation work, my coursework in 2011, I already did like a preliminary research about readiness and how do patients know that they are ready for surgery. However, I was not able to publish that because of all the other academic demands and all. But one thing that so that's the challenge. So I was not able to publish it. So someone was able to do a research on that, and this one got published already about the idea of readiness. And I'm citing this article because this article developed by Connor Spady in 2014 is that it is one of the novel researches that really highlights and discuss the difference between preparedness and readiness. And when you talk about readiness, it is basically the patient's feeling that they are both mentally and physically ready for surgery. So I was able to work on doing a tool. So banking on my previous researches, I worked on the development of a tool that measures patient readiness, and this was published in the Journal of Perianesthesia Nursing. And in the research that we developed, we highlight that readiness is preoperative patient's perceived connection, competence to undergo the operation. It primarily involves an active participation among the surgical patient. So again, we have to translate the view that the patient is not a passive recipient of care, especially in the aspect of surgical care. So now in that tool, readiness can be identified into two major factors and clustered into the quality information acquisition. So part of promoting readiness is that the patient, this encompasses activities that facilitate comprehension on the part of the patient and the discernment of the quality of the preoperative care to be rendered. Now, part of that also is the role of the healthcare team. We have to be there. And it's not just the team, even the family members. So these are actions that promote stabilizing activities with regards to the integrating our care to our patients. So just to give an overview or as I was saying, so going back, so I was saying that these are some of the components of readiness in the tool. So it highlights on checking on the track record of the physicians. They understood the risk. They understood, they felt that they received quality care treatment. Now, for the second factor, it highlights on identifying whether things that they have done to make them ready, like praying. So again, it's something that it doesn't involve only the medical side of it, but also looking at their family. Because, you know, surgery is a stressful encounter. So patients sometimes, or the persons undergoing surgery, sometimes they feel that they are stressed not just in the surgery, but they have to look after their family, they have to look after their children. And these are the things that the readiness tool measures for the patient. Now, also, part of the study is that it looked into the different patient characteristics that could probably affect readiness and could probably affect surgical outcome. So in this research, we focused on the 4 factors, which are your type of surgery, whether is it said to be a curative or reparative in nature. It looked into surgical risks. It looked into, this is categorized based on the American Society of Anesthesia. So they categorize patients to minimal, moderate, or high risk. Health literacy is a relatively new concept in the Philippines in terms of when I did my research, that health literacy is the capacity of an individual to obtain, process, and understand basic health information. And basically what we assume here is that the more literate, health literate. So it doesn't talk about literacy in the sense that you can read and write, but it's more of understanding the health information. So in health literacy, it talks about the ability to obtain, process, and understand health information. And the idea here is that if they understood more, you're supposed to be more ready, right? So that's the concept here. And then also anxiety, which is an unpleasant experience that the person will have prior to a surgical procedure. Now, in terms of the outcomes that we measured in the study, we talked about the pain rating score, which is the usual visual analog scale to determine their pain score. Also, taking additional pain medication is also considered as an outcome because we say that usually a patient who is more in control usually would require lesser pain medication. And then possibly developing complications, and this is according to different literatures, that usually requiring blood transfusion, usually having infection, usually all of these possible complications. So there's like a checklist that was utilized, and then the measurement of the satisfaction. Now, another thing that we need to evolve in is that we should not focus on satisfaction, but rather we talk about the patient experience. So this tool actually measures patient experience. So the primary aim of the research is to determine the relationship between and among the variables of the study, putting the readiness as part of its focus in the middle. So as when we talk about readiness, so it serves as a mediator or determine how readiness can mediate the characteristics of the patient and the surgical outcome. So if you will see in this paradigm, it doesn't highlight, because normally it doesn't go with the usual regression, but it highlights readiness as in the middle, because it is assumed or it is hypothesized that readiness can influence outcomes. So how these characteristics can influence the outcome and how readiness can mediate the achievement of certain outcomes. So the study is actually a quantitative correlational research which uses model testing and path analysis. It was done on four tertiary hospitals in Metro Manila, which caters to these types of surgical procedure. Inclusion criteria were 18 to 59, those scheduled elective. So we did not include in the study patients who are emergency, because again the readiness might be a different component with regards to the emergency procedure. So it's mostly elective procedures, and then able to understand English and Filipino. We look into we did not consider still in this study those studies with unconfirmed malignancies, because this will possibly affect the anxiety. So if it is sure already that it's cancer, then we included them. But if it is like doing a frozen section in the middle of the surgery, there is still uncertainty. So that part was not included in the research, or they were excluded in the research. So sample size was utilized. Actually, minimum sample size was 200, but the study included 376. So to achieve good power also, and at a significance of 0.05. For the research instruments, so these were the instruments used, and all of these are standardized tools. Have been pre-tested in a different or a separate sample and checked for reliability, and all of them qualified. The content validity was satisfied, then also the reliability was uh, recognized, and it's considered valid and reliable. So these are sample of the tool. So the tool, so just want to share this one. This is a new tool that I used here. It's not new in the sense, but it's seldomly used, because again, as I've said, health literacy is something that is not commonly measured, and hopefully now we're starting to have more researches that focus on health literacy. But this one measures health literacy. It's called the NUS Vital Signs. So there's like a nutrition fact question, and it checks on how or if the patient understood that nutritional label. And then you have for the anxiety, you measure the preoperative intrusive thoughts inventory. And then for the experience, we have the SCA8. Okay, so that measures the surgical experience. For the data gathering procedure, so basically in the research, what was done is that patients were approached preoperatively. The data was gathered preoperatively, and then after the surgery, within 48 to 72 hours, we came back again to gather the data for the post-operative or for the outcomes. Okay, so so those are the tools that was measured 24 hours prior and then 48 hours prior. And then the study made use of descriptive and inferential statistics. So we use covariance-based structural equation modeling, because the objective at that time is more of theory testing, so testing. And then path analysis to guide us in terms of understanding the relationship and the direction. Now, these are what you call model fit parameters. So in structural equation modeling, we need to identify a model that is said to be a good fit. So normally we start with what you call a hypothesized model, meaning this is what we assume, this is what we think, this is what we hypothesize. But later on, when we run the structural equation modeling software, it will now give us scores in this parameter. So these are parameters that we could see, and eventually we want to see a model that is said to be a good fit. We need to see a model that is said to be a parsimonious model, meaning a model that is somehow, it's succinct and it's very clear, and it's not really that confusing, I hope. So that's the idea for doing that model fit parameters. So for the ethical consideration, so the study adhered to ethics approval on 4 institutions, highlighting on the social value, informed consent, no vulnerability, risk, and all of these were highlighted as part of the ethical consideration. So let's now go to the results. because I was mentioning this is so if you saw the first paradigm that I shown you, that's the simple one. So now when you use the software for SPS, for structural equation modeling, the AMOS, so you will have to encode or put your variables here. So the variables are identified already and placed in that diagram. So now the study now, or the software will now analyze and check the fit of the hypothesized model. So based on that, so the fit showed the first one, the first line. So it's actually the chi-square and degrees of freedom. It's very high, although it's model. So the idea is that you have to trim the model. So step by step, so you will reduce or remove those variables that are not related or not significant. So you trim. So you call that model trimming, so that you will be able to come up with what you call your emerging model. So the emerging model now is said to be a good fit model. So compared to this one. So the idea is this should be lower than the Ramsey, so it's significant. Then usually this one, so the higher the score, the higher is the parsimony and the comparative fit indexes. So this is now what we recommend as a good model based on the sample or based on the study that has been conducted. So to explain, so before I show you the model, so before I confuse you, so we'll start first with understanding, starting from what you call your exogenous variables. So these are said to be the exogenous variables. So start with surgical risk, for example. So in the study, you would notice that surgical risk actually did not influence or does not have any relationship with readiness, but actually the risk, the higher the risk, it leads to higher complications. The higher the risk, it leads to higher requirement for additional or receiving additional pain medication. Next is the type of the surgery. So type of the surgery, whether it is curative or whether it is reparative surgery. So it showed relationship. So a curative surgery influences readiness. And you would notice that a curative surgery can also influence the development of complications, but it actually lessens the need for additional pain medications. Okay? Now, also, readiness serves as a mediator that can actually lead to increased surgical satisfaction. So if you will notice, so this one is what you call, it has direct mediation here, that the type of surgery doesn't directly influence the satisfaction, but when you have higher readiness, it showed an increased satisfaction. So that is what you call full mediation. Okay. Now, in some cases, partial mediation will happen when there is also a direct relationship on readiness or on the variable. Okay. So next, we talk about health literacy. Now, going back to my previous discussion, we assume that health literacy supposedly will increase readiness. However, it is worthy to note that in this study, we determined that health literacy reduces readiness. And this is something, it is an aha moment in the research that I have done. In what sense? Because we assume that health literacy actually should increase readiness. But if you will try to look further, sometimes if you know more, you tend to become less ready. Especially, remember in our study, we did not include healthcare practitioners. But let's say you are a healthcare practitioner and you will undergo operation. Sometimes you have a lot of questions that you end up not being ready for the surgery. Okay. Now, also, health literacy affects and it reduces, the need for pain medication, and health literacy reduces post-operative pain. Now, also, readiness mediates the satisfaction. No? So if you increase readiness, it could eventually help improve the satisfaction. But in this case, because the literacy reduced the readiness, it led to a reduction in the satisfaction as well. And last of the exogenous variable is the anxiety. And definitely, this is an expected relationship. Anxiety reduces readiness, but also anxiety reduces satisfaction. But the anxiety here, this time around, it did not increase the post-operative pain. So those are the things that we have seen. And then readiness has a relationship on these three outcomes. Okay, so you reduce complications and And these are because SEM look into the relationship, although that's not part of the main analysis, but we still have to put that because the SEM has shown relationship between these factors, which is logically explainable. Okay, so this is now what we call the emerging model. So this is the emerging model in the study. And as the emerging model, so this is now, it's like if you have a theory, this will be the theory that you are proposing now. So just to have a clear understanding, as part of our discussion today, we need to highlight that this study highlights that, readiness is beyond the physiological aspect of preparation. So we need to see, or we have seen in this result that when you talk about readiness, it is beyond the physiological preparation. It is greatly influenced by the mental and the emotional state of an individual. Now, furthermore, I think as healthcare providers, it is important to understand that the WHO surgical safety checklist did not incorporate mental and emotional aspects of surgical preparation. Therefore, it is important for us to emphasize or to highlight that knowledge acquisition and skills are important part of preparing a patient. Now, another thing that we need to understand is that patients are unpredictable. If you would remember in my earlier discussion, I mentioned that I'm an advocate of having standardized teaching. And one thing that I need that this study has shown us is that standardized teaching is not the way to go. We need to really talk to our patients. We need to, like one author has mentioned, it's Peterson. She mentioned that talking with is better than talking to the patient. So meaning the idea of communicating and discussing things with the patient is very important so that we can help them achieve better understanding and also actually develop expectations that are appropriate. Because the problem is, remember, most hospitals now look into the surgical experience as an outcome in their care. So when we talk about patients having, realistic expectations, it led now to better surgical experience. Now, another thing to highlight is that when you talk about health literacy supposedly should increase readiness, but in this case, it showed a reduction in the readiness. And as nurses and as researchers, as healthcare providers, we need to emphasize that, when we talk about readiness, health literacy, we need to really develop tailored instruction. So that's actually my advocacy now, is to develop tailored instruction so that it depends. It depends on how a patient or a person would understand the health teaching. So you have to be adaptive to the needs of the patient. And if they are more informed, they are more engaged. Now, probably one thing that I could also recommend is that come up with the measurement, because the newest vital signs primarily focus on the communication aspect of health literacy. But health literacy is a broader context. So we need to look into the critical dimensions of looking into the health literacy. Okay? So in conclusion, patient readiness is beyond the physiological aspect. It addresses anxiety and health. Addressing anxiety and health literacy is important in improving patient readiness. The mediating role of readiness in improving surgical outcomes emphasizes the need for a patient-centered and individualized approach in preparation. So for my recommendation, well, further testing definitely is important. So this is still a model, but when you continuously test these things, eventually it could become probably a practice-based, or hopefully eventually become a middle range jury through continued testing. Now, another thing is that, as I have said, in the intervention, we need to do a lot of experimental researches or interventional researches that probably will address readiness. However, actually, I'm currently doing a systematic review about the topic of readiness. And would you believe that there are only 6, in my systematic review, there were only 6 interventional studies that address somehow readiness, preparation, and actually there's only 2 that mention of readiness, and the results are still inconclusive. So that really proves that there's really a need for us to do further researches. And like doing phases, phases in terms of the intervention. Tailoring is very important as part of the recommendations for future studies. So this is what I highlight. Actually, in my study on readiness, the qualitative study that I did, the main theme or the main idea there is like surgery is like taking a leap of faith. Because readiness, when you decide to undergo surgery, there's no certainty on things. You cannot be certain. Even if you do everything that the doctor has told you, you will still be not sure of the outcome because there are complications that might happen. So really doing surgery is like taking a leap of faith. So it is our role as healthcare providers to assist our patients to develop informed decisions, calculated risks to help them be ready for surgery. So I think so. These are the articles. So you can email me if you want to have a copy of the article, so I can send it to you. And this is the other article, the one published in the Journal of Advanced Nursing. So this is my email, and I hope that this is a good opportunity. So I thank again the organizers for inviting me, because this is really a good opportunity for us to look into our role as nurses. And I'm very much happy to help and collaborate for future researches or those of you who are interested to work on this topic of patient readiness. So thank you very much, and have a good morning, good afternoon, and good evening.
So thank you for that wonderful presentation, Dr. Torres. So before we go ahead on the Q&A, I would like to invite our panel of reactors for a rejoinder. Just a reminder, please be sure to type your questions on the chat box. Professor Jerome.
Okay, good afternoon. Thank you very much, Dr. Richard Sullivan. At this juncture, I would like to introduce the panel of reactor, or basically only one reactor at the moment. We have an assistant professor from College of Nursing, San Beda University, Professor Gil Soriano.
Good morning, everyone. So I would like just to react to highlight some important points regarding the study presented by Dr. Torres. This is just a short reaction regarding his study. This study has highlighted several important concepts. First is the difference between patient readiness and patient preparedness, which we as practitioners sometimes use interchangeably. Second, the result is very interesting, especially the role of health literacy with patient readiness. So sometimes we tend to think that if the person has high level of knowledge in terms of the surgery, the patient will be more ready, which is not congruent with the result. This is really a good topic, and we need to conduct further studies in order to understand this concept better. Thank you very much.
Yeah, thank you very much, Sir Hill, for that for the appreciation, because sometimes, as researchers, it's also a challenge for us. I hope our audience was able to understand. I tried to make my presentation as basic and as simple in the sense, because sometimes, especially us in our culture as nurses, sometimes we dislike research, and I hope through this forum this is something that is really useful. And thank you for highlighting that health literacy is really important in terms of our role as nurses. And it doesn't only, again, just to highlight, there's really a difference between health literacy and literacy. So when we talk about literacy, it's simply their basic understanding of English, their numeracy, etc. But health literacy is really the ability to obtain, to process the information. So I really agree with you that we need to do more researches on this. And I think last year there was a call in the research of PCHRD to look into the health literacy of the Philippines, but I'm not yet sure if that study has been concluded, because I applied for that. I knew that because I applied for that, but I did not get the grant. But at least somehow the government is already looking into that importance of that health literacy. And I hope that as nurses, we try to look into this. We look into this in all other researches that we might be doing.
Okay. So thank you for that, Dr. Torres. Anyone from the participants? By the way, thank you for attending the participants. We are over about 100 participants in this international webinar. So if you would like to ask our speaker for today, you may do so, or you may introduce yourself and ask the question.
Dr. Richard, I would like to raise a point on Dr. Carlo Torres' presentation.
Okay, sir, go ahead.
I would like to rejoin on the from the cultural aspect. Meron bang ano ito? Meron bang significance ito from cultural aspects sa Philippines? I think Rodolph can cite an example on this.
Yeah.
Basically, good morning, Sir Torres.
Yes.
Hey, good morning, Doc.
The clarificatory, all of the participants are Filipino.
Yeah. As of now, the participants are Filipino. So because the setting is here in Manila, in Metro Manila. So as of now, the model is still Philippine based. Although the readiness tool, actually, I have some researchers from Turkey who already messaged me, and they wanted to adapt the tool for Turkish application. And that's the idea, especially when we develop instruments. We hope that we will be able to have it something that is universally acceptable, because probably there are some concepts which are Filipino focused mainly, or probably Filipino, but yeah.
Yes, I quite agree with that. Because in the Philippine context, we have this mediating factor of the concept of HIA. When we talk about the Philippine setting, HIA, H-I-Y-A. And more often than not, Filipino patient or some Filipino patient would not tell the truth, but would just tell the things that they think the practitioner want to hear. So that's one of the difficulties when trying to understand the context of Filipino patients. And unlike the counterpart in the West, they just tell you what they want to say as it is. But in Asian society, we don't function like that. So I quite agree with your point that the person is really unpredictable.
Yeah.
That's one of the highlight of what you said in the seminar, is that the person is really unpredictable. You cannot really predict how the person would do or what do. And we just hope for the better after all of our health teachings.
Yeah. Yeah, actually, just to relate the hiya or the being shy to verbalize things, in the paper, I think I mentioned that it also explains the pain, because sometimes Filipinos culturally will tend to I can do this, I can still bear the pain. But the idea is that when they are more ready, when they understand and they know that pain is a normal experience, but for us to manage your pain better, it is better that you verbalize to us when this is at this level, so that it can be addressed accordingly. And I think that is one that is reflected also in the model, that when a patient is more ready, you will see that there's also a reduction in terms of their requirement in the pain medication, and also the level of pain. So probably I do agree with you. That's why we need to really test the model, so that in different settings, in various settings, so that we get to understand. So I do agree that the HIA is there. That's why we need to make the patients more involved and more engaged, so that they will be able to really be part of the study. Be involved in their care. Yeah.
Okay, thank you.
Yes.
There is a question here from the chat box from Joel Ray Jacob. So he is asking, is there a health literacy Is the health literacy communicate with the same to that of indigenous people?
Well, I'll probably share first on perspective, and then probably I could ask my colleague here, Dr. Rudolph, who is really more into the indigenous people. But in terms of the health literacy tool, the requirement there is really the understanding. So meaning if they could understand the instruction. So the problem with the tool that I mentioned that is part of the limitation is that it's something that deals with numeracy. So if the person numeracy and the communicative. So if they don't know how to count, so they cannot use the instrument that I use. That's why there's still a challenge for us to develop. So that's another research that we can work on, develop. Probably Dr. Rudolph, you might want to collaborate and let's develop a tool for health literacy among the indigenous population or probably with those. So there are different types of tools. So yeah, so that's my answer for your question. So I am not sure in terms of the applicability in terms of the indigenous population, but as long as they know how to understand and comprehend and read, so they could use that instrument.
Okay. So are there any more questions from the participants? Maybe we would like to hear from you.
Yeah. Dr. Bethel has a question. Binati ko si Ma'am Bethel. Hi, Ma'am Bethel. Dr. Villarta. So there was a question here about elaborating on differentiating, communicating, talking with versus talking to the patient. So the idea there is that when you talk about talking with the patient, so you are there sitting, you are there listening to their concerns. Like what I have mentioned. So I have shared to you that I'm currently doing a systematic review on this. And one thing that is very important in that research is that patients are concerned about not just with the surgery. They are concerned about even practical issues at home. What will be the food that my family will take while I am being in surgery? How will I go home? Who will take care of my children? These are specific concerns that we can eventually address. So that's an example of what we mean by talking with the patient. Because normally we are used to talking to the patient. And when we say talking to the patient, we just say, okay, this is what you need to know. This is how you need to do the deep breathing. You know, you will be prepared. This is your surgery. This is how much you pay. Imagine even the payment, practical concerns. Payment is an issue for them. So that's really something that we need to look into. So we should not lose the caring component of being a nurse. So I think that's what we need to highlight, that in readiness, because no one is responsible for promoting readiness but us. It's something interprofessional as well. So meaning aspects of that involve the anesthesiologist, the physician, but nowhere in the checklist or nowhere in the hospital that is really in charge of taking control of the readiness of the patient. And I think this is a perfect opportunity for us to embrace our responsibility to really make the patients ready for surgery.
Dr.
Okay.
Gian.
See, go ahead.
Hello, Dr. Gian.
Yes, Dr. Rudolph.
That's actually an interesting point because from the perspective of caring science, most of us would listen to respond, not really listen to understand. And the main point of talking with the patient is listening to understand, not merely to listen to respond to the queries of the patient. So it's a very good point.
Yeah. Thank you.
Okay, thank you so much, Dr. Rudolph. Is there any more question? So if there's none, it looks like we have covered all of the questions. So Dr. Torres, is there anything else you want to cover before we wrap up?
Anything to add?
Yes.
Well, I'm just really excited to share this research, and I hope that, for us nurses, developing our science is really a challenge. So, like what I've said, it took me like almost since 2006 probably that I was doing my master's until I came up with this. And I do not say I cannot claim that I am an expert on this topic. But although based on literature, probably I'm a few of those who are, really doing or working on this. But again, the idea is that we need to embrace our role. We need to claim our responsibility, like what I am saying, that readiness is our role as a nurse. So let us not give it to others. We have to actualize our responsibility. So that's the idea of developing our science. So there's also continued testing. So if there's some of you who would want to collaborate, so we have to be open for collaboration internationally, so that the context will be something that can be applied in multi-settings. So as of now, it is currently in the Philippine context. That's why any researcher who is open to work on my tool or work with me on any other country, I'm open to collaboration, because that can help us. That can help us advance as a science. That can help us advance as a profession.
So the presentation has been great, and the question and answer, I think, has been covered. So thank you. We appreciate you being here at this juncture. I would like to thank you, Nursing for Humanity, in partnership with Beta Nu Delta Nursing Society, Filipino Nursing Diaspora Network, Educational Solution for Professional Advancement, and the Journal of Health and Caring Sciences. To Dr. Torres, thank you. To our panel of reactors. So, Dr. Hill, thank you very much, and thank you all for attending for this International Nursing Webinar Series. We do hope that you have learned much. Until the next, goodbye.